and proceed. So good afternoon, everybody. Welcome to today's webinar on a noon briefing on the OSHA Emergency Temporary Standard. Today, for reference, is Wednesday, June 30th, 2021. Before I get started, I'd like to go over a few housekeeping items with you. You should be seeing a PowerPoint presentation in the middle of your screen. There is nothing you need to do individually to advance those slides. We will take care of that for you. We are recording today's webinar, and we will make a link available to you after today's webinar. That way you can share with those from your facility who are unable to participate. The lines for our attendees are hard muted. Following the presentation, we will have an opportunity for you to ask questions. You will use the chat feature, which is located on the left-hand side of your screen. Simply type your question in there, and we will get to it as soon as possible. The Kansas Hospital Association would like to take an opportunity to thank our sponsors for helping underwrite this educational opportunity, including PYA and Spencer Fane, who are presenting on today's webinar. With us, we have Jeff Bushong, Healthcare Consultant Principal with PYA. He brings more than 3 decades of experience serving healthcare providers with a focus on consulting and advisory services in physician practice operations, performance improvement, and business development. And then we have Drew Brott, partner with Spencer Fane. Drew has an extensive experience helping companies with workplace safety incidences and industrial accidents that involve the intersect of health, safety, and environmental regulations and government agencies, including OSHA. I would like to now turn things over to Jeff to get us started.
Thank you, Haley. It's a pleasure and a privilege to be able to present with my esteemed colleague, Drew Brott, this afternoon. As you can all imagine, the situation with OSHA's Healthcare Emergency Temporary Standards is very much a fluid process. And in fact, as late as yesterday afternoon, the American Hospital Association sent comments and some recommendations to the department to request an extension on both the comment period as well as implementation. And we'll get into a little bit more of that. Just so you all know, from my perspective, I've spent a lot of my career on both the hospital side of our business as well as within the medical group practices. So I'm going to bring you a blended view with very much an operations kind of a viewpoint in today's conversation. Drew and I are actually going to go a little bit back and forth, so we will try to make our transitions as smooth as possible. We don't want you to get whiplash from trying to follow slides back and forth. But I'm going to start out today and talk about the applicability to hospitals, ambulatory centers, home health, emergency responders, and long-term care. It's a pretty comprehensive list, and as you will see in our presentation, when OSHA published this, it was a little over 900 pages worth of information, so lots to digest. We are going to obviously hit on what we think are very relevant high-level points, and we will certainly be able to address some of your questions. The one caveat I think that we would all understand is that your actual experience may vary a little bit. So if some of our responses are, it depends on your current situation, please don't take that as our unwillingness to address your questions, but we will do the very best we can. So who's impacted by all of the ETS regs? Certainly the bulk of our participants today represent a variety of the hospitals and your membership within the Kansas Hospital Association. So anyone that would be listed as a general hospital, specialty hospital, a teaching facility. It's a pretty broad base, and because it's an OSHA standard, other than a few exceptions, it really, everybody gets to be included in the party, as they say. In addition to the hospitals, the bulk of various ambulatory facilities are also impacted. Many of the hospitals and health systems obviously have not only employed and contracted physician practices, medical groups, but obviously your independent physician practices are going to be held to these very same standards as well. And I think the whole focus is obviously making sure we're doing, as employers, the best job we can to protect our patients, our staff, family members. This is obviously, a global-wide pandemic where prevention and protection is a key component of that. In addition to the ambulatory, home health obviously fits right in there. So those organizations that have hospice programs, home health care, the whole variety of services, as well as those are providing in-home therapies as well, would all be covered as part of this. For the pre-hospital and the emergency responders, for those organizations that are involved in either the direct provision or contracting, this obviously applies to the ambulance companies, medical transportation, even for non-acute kinds of transport, as well as your air ambulance and your air evacuation services that are there. It also rolls all the way over into long-term care, including the skilled nursing facilities and the whole listing of the various residential treatment centers. At the bottom, I've included a link which will actually go through the laundry list of all of those organizations and entities that are impacted by this. So we're going to flip it back to Drew, and he's going to continue with our discussion.
Thanks, Jeff. Really appreciate that. And yeah, I agree. I'm really pleased to be presenting with you and PYA. Obviously, PYA and you in particular have a vast amount of experience with the healthcare industry. I am not a healthcare specialist, but I am an OSHA specialist. And historically, I've worked with a lot of manufacturing companies and heavy industrial. I do work with a number of healthcare clients as well. And my client list over the last year, as you could imagine, has increased exponentially in a COVID world. So dealing with first the general duty clause and the PPE standards and helping folks get into compliance with those and OSHA's guidance, and now more recently the issuance of this emergency temporary standard, there are a lot of moving parts very quickly. The one other area that I would mention on the applicability front relates to state employers and public employers, and making sure there's not any confusion there. As Jeff mentioned, the rule applicability is extremely comprehensive in terms of private employers. Throughout the country, we do know that there are various hospitals that are a creature of statute, either state statute or perhaps even a county-run situation. So you might have a county hospital, for example. Don't think, however, that the rule doesn't apply because the hospital itself was created as a political subdivision. You need to pay very close attention to whether there are any private employers or private employees that are conducting activities in which there would be interface with patients or with other staff or with visitors that might be related to COVID. Right now, Kansas Department of Labor, which has responsibility over public employers in the state of Kansas, has not yet weighed in yet whether they will actually adopt the standard for state-run, county-run exclusive facilities. But they do believe at a minimum it's going to be guidance. But I would note again, if you have any private employees that are providing services through contract or management agreements or otherwise, then there is going to be, OSHA is going to take the position that those private employers and those private staff, even if it's otherwise considered potentially a county or state-run facility, that this rule is going to apply. So I just wanted to point that out. It is kind of a confusing area, and we can provide additional background on that. Real quickly, what is the genesis and background on the emergency temporary standard? when the new administration took office in early January, immediately there was an executive order that was published. And the current administration, as part of this executive order, identified that on or before March 15th, that OSHA was to issue an emergency temporary standard to protect employees at job sites from the risks of COVID-19. A couple of other things, of course, came out of that executive order, including various enforcement efforts, as well as a national compliance initiative related to COVID. And this wasn't just the healthcare sector. This was for all employers around the country as a whole. Well, the March 15th deadline came and went, and that emergency temporary standard was not adopted. However, that does get to where we are now. I've thrown in a couple other slides here about some other executive orders that were issued immediately on January 20th, just for background on sort of the national crisis that we were facing over the winter. Of course, now with a large vaccine rollout that has taken place, we are in a much different place right now. The emergency temporary standard was issued in the Federal Register on Monday, June 21st. So that was just a little over a week ago. We're about 10 days in right now. That emergency temporary standard took place immediately. I want to make that clear. The rule was effective immediately. That is very, very different from notice and comment rulemaking in this country. Typically, under our Administrative Procedure Act, when a federal agency wants to implement a rulemaking, an administrative rule, there is a procedure under the APA in which there is notice and comment rulemaking. And sometimes this process will take months or even years, in which a proposed rule is published in the Federal Register. There's a period of time for comments to be received. And then after that, the agency weighs those comments and will issue the final rule. That did not happen here because Congress, in the OSHA Act, has a specific provision that mentions and identifies that in situations of a grave danger, the agency can take immediate action through the issuance of an emergency temporary standard. And what happens is that emergency temporary standard is issued immediately as an interim final rule, subject to a 30-day comment period. So right now, we are in a 30-day comment period in which any person could choose to comment on this emergency temporary standard, but the rule is in place. I want to make that very clear. The rule is effective immediately. Not only is the rule in place, but there are two compliance deadlines with the rule that are currently in place, and I'm going to talk about those in a second. One is July 6th. The other is July 21. As of yesterday, there have been no challenges filed by hospitals or healthcare systems challenging the effective date of the rule, the compliance deadline. So right now, as of today, June 30th at 12:20 Central Time in Kansas, all private employers in the healthcare sector that are covered employment sector that Jeff mentioned, all those types of entities need to ensure that they have compliance with the deadlines by July 6th and July 21. Now, there have been two legal petitions that were filed concerning this new final rule. Both of them, however, we believe are related to expand the rule, not the rule, not to rein it back in. The first legal challenge was filed by the AFL-CIO and United Food and Commercial Workers to extend the emergency temporary standard to other employers beyond healthcare. And then the National Nurses Union also filed a petition, but we don't yet know exactly what their issue is, although they've said they're supporting the rule and want to improve the coverage of the ETS. So again, we believe both of these challenges are not taking issue with it, but are trying to make the standards even more stringent. I see there's a live comment here. Didn't the American Hospital Association file one? No, a legal challenge has not been filed yet. What Jeff mentioned was that yesterday, the American Hospital Association asked for a 6 months of extension of time. So they have not challenged the rule. They've only asked for a 6 months of extension of time to come into compliance, which would mean instead of a July deadline, there would be a December deadline. And they've also asked for 30 days to extend the comment period. So we don't know yet how the Department of Labor and OSHA is going to respond, but as of right now, everyone needs to assume that rule compliance is next week. Prior to this rule, there have been numerous guidance documents on healthcare facilities that have leaned heavily on CDC guidance, and virtually all of the OSHA enforcement on COVID-19 has been in the healthcare system. All right, the new standard, 29 CFR Part 1910, Subpart U. It is very easy to find. Again, I noted it was published in the Federal Register. Here's a link, June 21. Very easy to find. Just follow that link. Let's talk about what needs to be done by July 6th. I'm going to talk about that first, and then I'm going to move and talk about what needs to be done by July 21. I will tell you that almost nothing in here is dramatically different from what OSHA has already been saying to the healthcare sector with respect to guidance. There are a few curveballs. There's some areas that everyone's going to want to look at and pay attention. But for the most part, a lot of the overarching mandates that are in this new rule stem from things that the agency has already addressed in guidance. The things that are due by July 6th, first and foremost, you need to have a COVID-19 plan in place. Basically, you need to develop and implement a plan that identify and includes a designated safety coordinator to ensure that there's going to be in compliance with this program. Your facility would have gone through a specific hazard assessment of the facility, which includes an analysis of both non-managerial as well as managerial employees in going through this hazard assessment, and basically developing a framework and system of policies and procedures to identify risk of transmission of COVID. First and foremost, you got to have this sort of game plan. The nice thing that I will tell you is if you go to OSHA's website and just go healthcare COVID-19, you will see a number of reference materials that are very helpful to healthcare and hospital systems to establish your compliance and obligations. The agency includes a number of specific guidance materials that include checklists and various compliance plans that basically you can take materials almost off the shelf, if you will, and develop your program through that. So if you're struggling to find content or materials or need to know what to do on a bunch of these materials, I would encourage everyone to go to OSHA's website, because they do have a playbook out there for virtually all of this. So we talked about the COVID plan. Second, patient screening and management. OSHA has an expectation that these facilities are going to limit and monitor points of entry. They're going to screen and triage patients, clients, and visitors, and they're going to implement patient management strategies. That's point 2. Point 3 is that you're going to need to follow the CDC standard and transmission-based precautions. Point 4 is you're going to be providing personal protective equipment. So, and we're going to talk about the difference between face masks versus respirators in a second, but employers are going to be expected to have face masks available, and that employees are wearing face masks when indoors and when occupying vehicles with other people for work purposes. And if you've got employees that are interacting with suspected or confirmed COVID-19 patients or involved in aerosol generating procedures on COVID-19 patients, then there's going to be additional PPE required, including respirators, for example. The rule identifies specific procedures when there are different procedures on aerosol generating infection as well as cleaning and disinfection controls. That relates to the aerosol generating procedures. Physical distancing, pretty straightforward. Rules in place to ensure at least a minimum of 6 feet apart when indoors. Everyone should be well aware of cleaning and disinfection practices. Not a real surprise here. The rule language does specify specific standards in accordance with CDC guidelines, as well as high-touch areas, high-touch surfaces, resident rooms, medical devices, and the types of specific alcohol-based sanitizers and disinfectants that should be used. There is probably the most complex area that you're going to want to take a look at, relates to health screening and medical management, and what needs to be done concerning how employees show up for work, the screening that they're expected to do, who they're expected to notify within 24 hours, who they're expected to notify if they have a COVID-19 diagnosis, so on and so on. If you don't already have a robust internal process for your health screening for your own employees, private employees, the rules identify the requirements in that regard. The rule does not mandate vaccinations, but it talks about expectations for time off and paid leave for vaccination. And of course, there's a couple other notable additional requirements. Obviously, you can't take any retaliatory action against an employee for exercising health and safety rights that they may have. PPE needs to be provided free of charge to employees. That is, if it's required, PPE. And then lastly, probably the thing that I want to also make clear is that for record keeping, right now, if you've got a private employee and you're a private employer, and you've got an employee that has COVID symptoms and reports to the hospital, right now that record, you need to keep a record of that if they are admitted within 30 days of when they have work-related symptoms. Under this new change, it doesn't matter whether it's 30 days or not. Any sort of hospital admission for one of your employees needs to be logged on your OSHA log. So there is a slightly different standard right there in how that relates. I think that, okay, so those are the key provisions that are due by July 6th. A couple things that are due by July 21. Your facility is going to need to look at installing physical barriers where required. These are also known as engineering controls. Probably the most cumbersome aspect of the rule is that OSHA expects that your HVAC systems would be designed and maintained in accordance with manufacturer's instructions with air filters that are rated with a MERV rating of 13 or higher if your system allows it. So you're going to need to work with your building engineers and your HVAC contractors to evaluate those ventilation systems. And then lastly, of course, is training. Last area I want to touch on before I send it back to Jeff to talk about some of the nuance relates to this concept of respiratory protection and really what that means. For many, many years, OSHA has had a respiratory protection standard that requires that employers provide respiratory protection when employees are exposed to hazardous substances or chemicals or biological agents. Here, OSHA is saying for healthcare employers, if they are in and around individuals, whether they're patients or employees or visitors that are exposed or suspected confirmed sources of COVID, those employees are expected to follow the entire respiratory protection program under 1910-134. That's a standard that requires medical evaluation, it requires fit testing, it requires an actual written program, user seal checks, training. It's a pretty robust program. So if you've got COVID-19 patients at your hospital, you're a private employer, you've got employees that may be exposed. This emergency temporary standard expects you to meet all requirements for the full-blown respiratory protection rule. Absent those circumstances, this ETS has implemented what they call a mini respiratory protection program, where in various circumstances, even if you're not, even if you don't have employees suspected or that are exposed to suspected or confirmed sources of COVID, if it's anticipated that enhanced worker protection can be provided, that employees would be provided with a respirator and with training and a seal check at a minimum. So what is the difference between a respirator versus a surgical mask versus a cloth face mask? Most folks in the healthcare setting are very familiar with a standard face mask or a surgical mask. These are not respirators. These are face masks or surgical masks. A respirator is designed to actually protect the wearer as opposed to the people around it. An N95 mask is a respirator. An N95 is a respirator that qualifies both as an OSHA respirator as well as a face mask for FDA purposes. So that's the primary difference. I've included a couple slides here that talk about duties when respirators are required under the ETS versus situations where if an employee chooses to voluntarily come with an N95 mask, what OSHA's expectations are. So that was a very, very high-level pass at all of these new changes that are going to be required. Now, I will tell you again, a lot of these are not a whole lot different than the guidance that OSHA has already had out there for the past year. So hopefully folks are generally aware of most of these concepts, and there's not a lot of absolutely new information here with that. What I'm going to do is send it back to Jeff that's going to talk about a couple of the specific nuances regarding vaccination and some other areas. So Jeff, I'm going to hand it back to you now.
Thanks, Drew. And Drew really led right into some of these immediate key next steps. He described the hazard assessment. The one thing that I'll remind the participants is that for hospitals and health systems where you have ambulatory facilities, practices, these same standards are applicable. This week, I've been spending time with my clients here in Georgia, and one of the things that we had to do is go back and take a look at all of those standards and how they apply, particularly when you have multiple sites for your ambulatory, whether it's, in this particular client's case, there's a separate freestanding facility for their wound care program. The organization also has a dozen medical offices that are off campus. So making sure that everything in the ambulatory world is still held to that very same standard. OSHA, I don't think, discriminates between whether it's in an acute hospital setting, whether it's a long-term care, whether it's an ambulatory facility. But these same standards that Drew and I have been talking about are very much in play. We did talk about the establishment maintenance of an exposure log. And I suspect, like a lot of our clients across the country, much of what you've been doing since the advent of COVID and what you've done to protect patients, workers, the public in general, you're doing many of these things. And I think that the OSHA emergency temporary standards were just kind of a reinforcement. That's clearly an oversimplification, but I think it does certainly bear reminding all of us that many of these things that we're doing in our organizations are very applicable. The COVID policies and procedures, what do we do? How do we do it? In this particular client, we have a highly coordinated effort between not only what's happening on the acute side of this organization, but everything related to the ambulatory. So we may have work groups focused on those various outpatient ambulatory settings, but it all rolls up into more of an organization-wide approach. I think as you go through and you read more of what's in the emergency temporary standards, a lot of focus on not only initial training, but also retraining, the reinforcement of those training procedures and policy. Obviously, one of the things that we continue to focus on is when new employees come into the organization, that part of that orientation and ongoing training is very much COVID focused because they're coming into this environment. Just as our colleagues at Spencer Fane at PYA, we've published some thought leadership that is kind of good reference material that I'll give you kind of a top 10 list, if you will, if you want to make sure that you're checking the overall big boxes. We would encourage you to look at both of our websites that bring and distill some of the clarity. This probably doesn't bear repeating, but certainly there are 3 vaccines that are approved for emergency use. Many of your organizations have offered 1, 2, or in some cases all 3. And certainly I think what's happened in this spring is the expansion of those guidelines to persons age 12 and older. I'll pause for a minute because one of the things that I think Drew mentioned, and it bears repeating, it's still very much a personal decision, but as a healthcare organization, we're obviously in the business of not only, curing and intervening when people get sick or injured, but it's also about prevention. And so the wearing of masks, the mask guidelines, depending on kind of what has been your experience in your various communities in the service areas where you provide care. But it's interesting, I think the newest variant that's come has certainly got this more front and center, as we like to think that we're returning to kind of normal. I think it's something that is not going to go away in the short term, and we need to just make it as part of our daily activities. But I thought it was interesting in the Federal Register, OSHA statement about kind of reminding people that, OSHA's focus on vaccination of employees against preventable illnesses, and it's that whole exposure on the job that you heard Drew make several comments about it. The obligations and responsibilities that we have as leaders in our organization to really protect, our employees, our staff members. This also obviously is in some organizations applicable to the vendors that provide services. When Drew was mentioning about the CDC standards for cleaning and sterilization, in some of our organizations, we have outside contractors that may not be direct employees of the organization, and yet those standards still have to be held to the organization sponsor. So don't want to lose focus that because we have outsourced and vendor relationships, it does not certainly get us out of the business of making sure that we're providing adequate protection. Communication, I think, since COVID started, has been one of the hallmarks of where I've seen some of the best programs, and also some of the programs as it relates to where there have been shortcomings. This is an ongoing reminder, I guess, to make sure that we have to communicate to our employees, why wearing face masks, throughout our clinical areas, with certain exceptions. The social distancing, the patient care areas, that limiting of access. Your organizations may be different, but I still see in most organizations I'm working with, there's highly limited visitor traffic in and around the patient care areas, and yet we know that families and caregivers and loved ones play an important role in the healing process. But also we have to make sure that throughout that course that we're being diligent in that process. I mentioned the cleaning and the disinfecting. Just a couple quick bullet points about what must employees do, what must the employers do, and Drew mentioned most of that, but that daily screening, before the workday and before the shift, we've got to make sure we do the temperatures, we've got to make sure we have those logs completed. And if there is exposure, making sure that, we are notifying coworkers that potential exposure may have occurred because of a fellow worker that may have been exposed to COVID and or may have COVID symptoms. I can't reinforce again, the importance of training to make sure that it's an airborne illness, that making sure that we are diligent in our efforts continues. What do the employers have to do? Certainly listed. We've included this really as more of a reference as anything else. So with that, I'm going to turn it back to Drew.
Thanks, Jeff. I'm trying to answer some questions here real time, so apologies. There was a little delay as I've been trying to answer some questions. Thank you, Jeff. That was extremely helpful. Much appreciated. So let's kind of get into now, where does the rubber meet the road? What does this all mean? We have all these, I'm bouncing around here with my slides. There we go. We have all these agencies that are responsible for worker safety. And of course, the healthcare industry and healthcare facilities are extremely familiar with the CDC and Health and Human Services, as well as NIOSH, NIH. OSHA, of course, is responsible for protecting employees. And so private employers are subject to the OSHA Act, as are private employees. The guidance that's been out there has been, until now, has applied to the healthcare sector. The OSHA Act has a general duty clause in most of the COVID-19 enforcement until the issuance of this ETS has been under the general duty clause. And so, in other words, a private employer that is running a healthcare system or a hospital and has private employees has a duty to protect those employees in the work site and provide a place of employment free from recognized hazards that are likely to cause death or serious physical harm. OSHA had identified healthcares and labs among the very highest risk categories, and consequently, for the past year and a half, OSHA has expected that healthcare employers provide a hierarchy of controls to eliminate the hazard, to replace the hazard where they can, implement engineering controls, administrative controls, and then lastly, PPE. Let's talk a little bit about what OSHA's enforcement authority. I would tell you that right now there has been extremely significant enforcement that has been brought by OSHA against hospitals and healthcare systems and a variety of different nuances. I'm representing several different healthcare employers around the country right now in OSHA enforcement cases. And the enforcement cases there, again, they're not being brought as a violation of the emergency temporary standard because that wasn't implemented until last week, but there are cases being brought against those employers under the general duty clause or for failures related to PPE or respiratory protection. OSHA's enforcement authority right now, as of January 15th, 2021, for a serious or other than serious violation is approximately $14,000 per violation, and the penalties can go up for failure to abate or a willful or repeat. Most of the enforcement cases that I've seen for the healthcare sector have identified a handful of relatively small penalties and small citations, with enforcement cases maybe anywhere from about $10,000 to $50,000. Most of these cases that have arisen were the result of fatalities in the healthcare facility, and following that fatality, OSHA came out and did an inspection. So that's one fact pattern that we're seeing. Another fact pattern that we're seeing are where employees actually file a complaint or make a phone call to OSHA to say, hey, my employer is not providing me adequate PPE, or they're making me go into the isolation ward or the hot ward, hot zone, and they're not giving me gowns or any face shields or things like that. So there have been a number of complaints that have been filed with OSHA. The most common COVID violations we've seen historically over the last year and a half have been, again, violations concerning respiratory protection, PPE, and record keeping. I'm going to skip through these just due to time. Little bit about the number of complaints that have been received. Massive number of complaints nationwide, both between federal OSHA programs as well as state OSHA programs. You can see federal OSHA has received over 15,000 complaints and several thousand referrals. They've closed about 80% of those. State OSHA programs have received over 60,000 complaints, and they're at about the 80% mark of getting those closed out. Most of the complaints that we're seeing come from these types of facilities. Again, not a surprise when you look at the most significant complaints that are coming in. They're coming in from healthcare-related facilities. And I'm sure that Jeff and his PYA colleagues themselves are quite familiar with the type of counseling they've provided to different healthcare systems and hospitals to work through procedures to make sure employees are being protected. There, of course, is also whistleblower protection. Whistleblower protection is different from the complaint. So this is a situation where an employee alleges that they actually were retaliated against. So some employees have alleged that they were either fired or demoted. They lost hours. They may have made a complaint to their employer that said, hey, I don't think it's fair that you're making us go in there and we don't have proper PPE. And then next thing they know, they were fired. And so there have been a number of whistleblower complaints that have been filed over the last year and a half as well. These numbers are across all sectors, so it's not just hospitals and healthcare systems, but in the past year and a half, 5,500 individuals have made allegations that they either were terminated or somehow demoted, suspended, or otherwise for exercising a protectable interest that they had. This just kind of gives you a map that shows the increase in the number of whistleblower cases that have taken place around the country in the past year. I think that that's probably really all that I wanted. We're at 12:50, and I think, Jeff, maybe what we can try to do is get through any other remaining questions. It looks like a couple of other questions have come in the remaining time. That Haley and KHA folks, does that make sense?
Yes, that does. We also just have gotten a lot of questions about sending out the slides. We will be sending out the slides post-webinar. I know that in Jeff's presentation part that we didn't get to is about communicating to employees and other issues, and he has a really great slide on that. So we'll make sure all of those slides go out to the attendees.
One of the questions I see.
Go ahead, Jeff.
Is asking about business offices. Are those exempt from ETS? It's my understanding, and I would ask Drew to confirm that, no, I don't think they're exempt. I think one of the challenges are in kind of non-patient care areas is the social distancing component of it and the physical barriers. Drew, how else would you answer that particular question that David posed?
I want to look at that and daisy chain or just kind of confirm a couple points on that. That's a good question. I do believe, and I'm pretty sure the rule includes provisions that talk about if everyone is fully vaccinated. There's an exemption if everyone is fully vaccinated from a lot of those challenging requirements. And so I suspect that either between a carve out for an office setting or maybe one of these exemptions, there may be a way that a purely administrative office setting in which there is no patient care occurring, and you can, I mean, I want to make clear, we're not talking about a situation where you've got folks on the fourth floor that are doing just the billing, but you know, they're going in the front door and they're walking down the halls and they're going to the cafeteria. I mean, to me, that's not that doesn't fly. That's part of the healthcare setting, and you're going to be in. But if you're talking about a satellite building, administrative support, office support that has no interaction whatsoever, I suspect that there's probably a carve out somewhere in there. That's just sort of my initial reaction to that.
Thanks, Drew, for that answer. I have a couple questions that we can get to in the next several minutes, and I will make aware to our attendees that Jeff and Drew have both offered to take these questions offline and do a FAQ for us. So keep sending your questions in. We'll get to as many as possible, but I'm going to do some rapid fire real quick. One of the questions, Drew, you could probably answer is, do you have to go back to March of 2020 with your exposure logs, or do you start that now going forward, that OSHA differentiating of the 30 days of admitting from hospital?
You would begin that now.
Perfect. Can you please expand on the N95 wearing as we use the surgical mask unless an AGP is occurring? And Drew, I know you answered this one as well earlier for somebody else, that N95 mask and wearing those. I know that there's several questions in here about the limited supply and that how OSHA is changing that a little bit, or may not have actually been a change, but suggesting you wear them.
Yeah. Yeah, so an N95 is actually a respirator. There's a lot of confusion. People will call N95 a mask. It's not. It is classified and regulated as a respirator by OSHA. So at least from OSHA's perspective, if you've got individuals wearing an N95, that is a respirator. And if the employer makes a determination that the reason they're wearing that N95 is because it's necessary to protect them, then all of the rules related to the respiratory protection standard will apply as opposed to the mini respirator standard here. If you've got individuals in surgical masks or cloth face masks, and of course surgical masks, you'll follow, you know, I'm sure everyone's familiar with those, with FDA or CDC guidelines. Here, OSHA is saying if you've got employees that are going to be exposed to COVID, then there's going to be an expectation that they are in a respirator, which would include an N95. Does that help?
Yes, thank you, Drew. Next question. When OSHA comes in for these drop-in inspections related to the OSHA ETS, can they also look at everything else OSHA related, or do they only get to stick to the ETS?
Unfortunately, everything becomes fair game. Now, we kind of talked, what's the reality? OSHA does not have the time and effort to do audits at every single facility. It's just not going to happen. How and where it's going to happen is if you get a complaint, or if you have a cluster, an outbreak of employees that are admitted for COVID symptoms, and you're reporting it, or you're reporting a fatality. Those are the circumstances in which OSHA is going to come out and do an inspection. Now, I can't guarantee they're not otherwise, because of course they are doing sort of random routine spot checks, but they simply don't have the staff to go around everywhere. But when they do come out into your facility, OSHA is not limited to simply looking at the ETS for COVID. So for example, they might ask questions. There's been an emphasis on a focus in healthcare facilities concerning violence in the workplace. You might see things concerning ergonomics and questions. There is no formal OSHA rule on ergonomics, but there's guidance on ergonomics, so that, you know, it's not out of the realm or the ordinary to think that you could get questions broader than just compliance with the COVID-19 emergency temporary standard.
Thank you. Next question, do you have any comments about conflicting information between the CDC and OSHA guidelines, for example, the masking and social distance guidance for vaccinated employees?
I'm sorry, can you say that again?
Yeah, I can do it slower, sorry. Do you have any comments about conflicting information between the CDC and OSHA guidance in relation to vaccinated employees?
So, Jeff, you may have your own thoughts on this. So I believe that OSHA will defer to CDC that if you have fully vaccinated individuals that don't otherwise present with underlying health complications, OSHA will say we will agree to and follow CDC rules. And so you can have fully vaccinated individuals in that situation that are exempt from, you know, the onerous requirements.
I would agree 100% with that, Drew. I know there were several questions about non-clinical spaces and the gathering of vaccinated employees, and I think what Drew's response was, and I think there's just good practical advice. I know there's questions and concerns that I've seen in some of the posed questions related to how much can you ask about who's been vaccinated. My guidance is always the common sense approach. You know, if you're in a large conference room and you're socially distanced and you go in with mask and the question is, has everyone been vaccinated? I've seen cases in many of my client spaces where, yes, as long as all the participants are comfortable. If not, you know, the advice is to mask up.
Everything I was going to say, I'm not concerned.
I see.
Go ahead, Drew.
Oh, I was going to say, I see a question about should we switch back to N95s for general staff not providing healthcare services. My general answer is no, you should not. The only time, again, an N95 is a respirator. And so if you give someone a respirator, OSHA is going to assume that that means you've made a determination that that respirator is required to protect them from getting COVID. Once you've given folks and supplied them with N95 respirators, you're going to have a respiratory protection program in place. Now, OSHA says if you've got individuals working around suspected or known COVID patients, you are required to have a respirator for those employees. But if you've got folks that aren't around those patients or employees, then no. I mean, I would be continuing to only simply be using non-respirator protections, which would be the cloth masks and the surgical masks. I see another really good question in here about recording. Should we be recording temperatures? This presents a little bit of a dilemma because certain information that you record for employees theoretically could be a health-related record. And OSHA, if you store health-related records, OSHA takes the position those have to be stored for 30 years. I think there's a good basis to argue that simply taking a temperature may not qualify for that 30-year record-keeping requirement. But the better practice and what I tell clients is, as part of your monitoring and screening, certainly have them take temperatures, but you can indicate simply, you know, whether there's an issue without actually any of the vitals. So that's generally what I recommend for folks in that situation.
When they say, yes, you need records of all your temps, I do understand.
All right, and it looks like we're right about the 1 o'clock hour. As I mentioned, Drew and Jeff offline will be taking the rest of these questions and giving some general statements. So we'll keep this open just a little bit longer as we close out today's webinar. I think we hit on a number of topics, raising some really good points and some really good questions. ultimately, I think KHA's stance is you really should be talking to your internal team, your internal legal counsel to be making these plans and putting this into enforcement for OSHA standards. Jeff or Drew, do you have one final comment?
Go ahead, Jeff.
Just wanted to thank all the members for the opportunity to share some of our experiences, and certainly here to help in any way possible. And as Haley said, we will address your questions, and that'll be sent out as an FAQ. So thank you.
Yeah. Haley, will this Q&A still be open for another couple minutes while Jeff and I try to work through it, or will it just close out? Or
It'll be open a couple more minutes, so you can continue answering those questions the way you have been. If we close it out and you don't get to the rest, I'll pull them and send them over your way through email. So I'd be on the lookout for this in the next couple days. They'll try to get to it quickly, but we'll get to it.
Yeah.
All right.
Perfect. And
well, I'm going to conclude today's. Go ahead, Jeff.
My only closing thought real quickly is that I expect, as much has changed in the last week, I would fully expect to be in for a full ride for the next week. So even though we have a July 6th deadline, don't be surprised if next Tuesday or Wednesday something happens in which either the agency agrees to the request from the hospital association or a lawsuit is filed. So it's possible that none of this goes into effect next week, and it's possible that none of this goes into effect ever. So just buckle up and be prepared, but, there could be a lot of changes.
Buckle up and be prepared. That's great advice, Drew. That does conclude today's webinar. Be on the lookout for the recording. And again, thank you to PYA and Spencer, Fane, Drew, and Jeff for presenting and really partnering on this. It was a great webinar and a lot of useful information. There's nothing you need to conclude today's webinar but to hang up your phone line and close your web browser. Thank you, everyone.